why we need that the European Beating Cancer Plan to acknowledge the importance of research in cancer. We have the mission for cancer, and was of the top missions of the Horizon Europe program. And of course, we need to build synergies.
Please.
Thank you very much, Cristian Busoi, for this meeting. I'm very glad that ESSO was able to organize the review with so many patient organizations this meeting, and that there are so many people there, like President De Lorenzo. And you know, I'm doing this for 30 years now. What I know for my patients, if I would be a patient, what I would expect is to get as quickly as possible if I have a solid tumor. And I want to do it by somebody that does it often and is qualified for that. This is my expectation. More than that, I would like to have less complication, or no complication if possible, and a good quality of life. So basically it's easy and everybody knows it. But if you talk to people from our ministries or with others outside, the information they get from media, and you said it, it's rather focused on pharmacophilia, on drugs, on immunotherapy. That is sexy, and surgery is old-fashioned. There are a lot of operations that are unnecessarily performed, and a lot of operations they are not of good quality. So this is it's a big problem for us. So the question is, do patients, do citizens have enough information on how to judge upon good surgery? And I will show you just a short presentation regarding this so-called invisible cure. You see, the surgeons don't have any faces. So who's doing all this? And Anna Waxter from Cancer World, maybe if you don't read it, can read it, I will read to you. The best chance of being cured of cancer is through surgery by expert surgeons with a deep knowledge of oncology. We all agree on that. But why are then the public, patients, and policy makers so focused on drugs, and does it matter? And I wanted to check it in Germany, and I had a help from a medical colleague, which is journalist at Stern, which is a very famous German magazine. And he looked at all the publications regarding cancer in the print media between June 17 and April 18. And he found 101 articles published, and 35 of them were focused on new drugs, immunotherapy, genetic therapies. 22 were focused on general facts, epidemiology, and 7 on early detection, only 7. And at the end, only 2 of them mentioned at all surgical oncology, and only 11 articles had the words operation or surgery mentioned. So, and this is a country with 90 million inhabitants, and this is the situation all over Europe. So the perception is completely different than the one we have here among us. And as we said, it's basically simple. 80% of all patients with solid cancer will get a sort of operation during their disease, either curative or for palliation. If you look like in 5 years or times or more in 2030, we'll have 45 million operations all over the place, over the world, and just a few of them will get basically less than 1/4. We get a safe surgery, affordable at the time they need it across the globe. And we have these inequalities in Europe as well. And also, you said it also, and everybody knows it basically. Surgical resection is for cancer that is diagnosed early the best option to cure patients. And this is really for all solid tumors. It's breast or it's colon or lung, and will be for bladder as well, and for other entities. And what we have to think about today is that these costs related, the treatment-related costs, are less than for medical oncology. You know, if you prolong for our patients the life with immunotherapy, even though it's just for maybe 10% of our patients at maximum, it costs a lot for a survival benefit, which is a few months, and we have to be aware of that. And they get a lot of side effects as well. And coming off that metastasis is offering for less money, basically similar results. It's not a plenary for surgery alone, so it's clear that we have to do it by multidisciplinary, but we have to think about cost today more than we did like 2 years before. And just to show that that also surgery has a lot of other functions regarding prophylactic operations for hereditary syndromes, which is becoming a more and more issue. Very important. We ignored that like 20 years ago. Now we do it. Just think of all patients with potential breast cancer and so on. For diagnosis for metastatic disease and mentioned, but also for palliation. Sometimes is a operation performed with less complication, with no complications, a better option for the patient. So finally, we represent with ESSO a lot of countries and a lot of organ societies and national societies. So, but our credos, we speak for our patients. So we have no lobby. We're surgeons. We operate until evening. Then our day starts, and all the policymakers are maybe have finished their job that day. So we need your support. We need your support. We need the support of the European Commission and also of the European Parliament, because our first credo is excellent in patient care, and we represent our patient. And again, I'm very thankful for this meeting and for the opportunity to talk to all of you about all these issues, and very much forward to the next presentation. Thank you very much.
Thank you, Pio. I think there will be a lot of Q&A at the discussion moment. Now it's my time and pleasure to introduce you the next speaker, who is Mathias Schuppe. He's a deputy of unit from the GSMD, that is a European Commission Directorate that is located in Luxembourg, and we are very anxious to listen to your presentation.
Thank you. I will briefly take you through some of the key actions of the Europe-Speeding Cancer Plan that are relevant to this field, to medical or surgical oncology. Just to outline the plan, the Europe-Speeding Cancer Plan takes a holistic cross-sectoral approach. So it tries to address the entire disease pathway, starting from prevention, early diagnosis, treatment, and then also trying to address quality of life issues of cancer patients and survivors. And I think this holistic approach is also quite relevant for surgical oncology, where I think different specialties have to work very closely together. And I would like to highlight a number of flagship actions of the plan that we think are important for the sector and important also to improve the quality of cancer care in Europe. And the first one I would like to mention is the aim to create an EU network of comprehensive cancer infrastructures by 2025. So we have quite a large disparity within Europe. Some member states have already established comprehensive cancer centers, comprehensive cancer networks. Others are, let's say, not so far advanced. And the idea behind this plan, which is funded also by projects under the EU for Health program, is on one side to support those member states that are not yet there to establish and further development their infrastructures, and then on the other side to network these infrastructures across the EU, building also on the example that we have, for instance, of the European reference networks that deal with rare disease, so that we have basically this exchange of experience, training, clinical trials across the EU to improve quality. And of course, in these centers, that will also be a place then for medical oncology and also, surgical oncology, and also for accreditation of these centers in order to improve the quality. Linking to that is also the work the Commission has already started before the plan was adopted on EU guidelines for screening and treatment of certain cancers. So we have the EU guidelines for breast cancer. Last year, we have launched work on colorectal cancer, and we are also working with IARC now to update the guidelines on cervical cancer. This is linked to the Council recommendation on cancer screening, and we are currently in negotiations with the member states and the Council on the basis of the new Commission proposal on cancer screening that was adopted on the 20th of September. And besides these three cancer sites that I mentioned already, should also cover prostate, lung, and gastric cancer. Then perhaps another key area is the training, which was already mentioned here. We have launched as part of the cancer plan an interspecialty training. The first cohort actually was presented here in the Parliament before the summer break. And we have already launched the call for the second cohort. And this first cohort has a focus on oncology, surgery, and radiology, training in these areas, and then also further expand with the cohorts, focus on other specialties, including also on nursing. Perhaps to mention a few other initiatives that we also are planning to launch, I think which is of relevance, the European Cancer Imaging Initiative, which should be launched towards the end of this year, beginning of next year, where we try to establish an ecosystem to develop new methodology in terms of cancer imaging, trying to make Europe, let's say, a world leader in developing new methodologies and new approaches to diagnostics, but also relevant for treatment. The Commission has, before the summer, launched its proposal for European health data space. Here also relevant that cancer patients can access their health data, that they can share the data across borders, but that we can also have access to these data for research purposes, for instance. And that will also then help to develop further high quality treatments and validate existing treatments. Perhaps in closing, just to mention two other areas, the prevention area, which is again a quite holistic approach. We have launched action to address cervical cancer by improving HPV vaccination, and of course also improving the screening for cervical cancer. And coming back to the issue of inequalities across the EU, this February, the Commission has launched the first phase of the Cancer Inequalities Registry, where we basically track disparities and inequalities across member states, but also within member states, taking also into account the gender dimension and also socioeconomic inequalities. This will be the first phase. In another phase, and this will be launched in February next year, will be cancer country profiles. So basically looking at the individual situation in each member state, again, in a holistic way, starting with prevention, early diagnosis, treatment, that we can have a better focus here what's happening at the national level, and use this information then to make decisions about further investments, both at national and EU level. And with this, I will close my presentation. Thank you.
Thank you.
Thank you so much. I'm very glad now to introduce Mrs. Alina Comunescu. She is a board member of Digestive Cancers Europe. She will present us the importance of surgical oncology in the patient's pathway. Please, you have the floor.
Thank you very much for inviting me here, because representing Digestive Cancer Europe, I might highlight the fact that in the first stages of colorectal cancers, surgery is the best option for treatment. So let's talk about the importance of surgery in the patient pathway. I started my advocacy journey more than 10 years ago. So this is how it was then, and this is how it is now. An optimal patient pathway is directly linked to a patient-centered approach. How it was when I started the advocacy pathway, it was, we were talking about medical center approach, and right now we are moving toward the patient-centered approach. A very important study showed that multidisciplinary approach is the best way to deliver the complex care needed by cancer patients. However, it is a challenge that requires both organizational and cultural changes and must be led by competent health managers who can improve teamwork within their organization. This evidence showed that in many circumstances, care planned by tumor boards is concordant with best evidence recommendation, about 66%. But in some cases, around 23%, there is a discordance between the recommended and delivered care. This discordance was shown to have various factors, but the main one was related to the lack of patient-centeredness. So, what are we talking about right now? The efficiency of care pathway is a key problem area for all those involved in the healthcare system, which face their own challenges. So let's start from the top. We were talking about healthcare authorities who are tasked with making the healthcare system more efficient and modern by optimizing patient care at the local, regional, and national level, curbing inequality in access to care. So here I want to quote my colleague speakers that the non-recognition of surgery oncology as a specialist discipline in the EU is causing disparities in training, qualification, and practices. As far as I've seen in your report, currently only 8 countries recognize it as a specialty in the European region. So we have to advocate, all of us, to be recognized this subspecialization that would help harmonize and raise standards in the discipline across Europe, thus reduce inequalities in access and improve the quality of patient care. As you've already mentioned, surgical treatment is integral to multidisciplinary care. So comprehensive cancer care centers will support patients throughout the whole disease pathway: prevention, treatment, clinical trials, rehabilitation, and these are associated with the better patient organizational and professional outcomes. Second, we are talking about healthcare professionals that seek ongoing improvement in their practices in order to provide the best possible care for their patients, better coordination with all the stakeholders in a sector. So I want to highlight here the importance of research and innovation that you've already said it's somehow paramount in the treatment area, but less recognized at the surgical oncology area. But we also have to highlight the fact that the best surgical oncology approach could somehow provide a safety, efficacy, and cost effectiveness of patient management. Because, of course, I'm representing Digestive Cancer Europe, we are advocating for screening. So the opportunities that arise from early detection are not fully exploited right now. Screening programs can detect cancer at early stage when curative surgery has a greatest chance to success. And let's reach what we are interested in. Of course, the patients who become increasingly involved in their care. In my opinion and in my experience, we, the patients, are looking to access the best treatments, to improve the quality of life, to better control their emotion, and to access a comprehensive services with coordinated care in order to maximize their chances of recovery. So we are talking about a patient-centered paradigm shift that is needed to improve effectiveness of tumor boards. Let's explore the digestive cancer case. So, improved screening and early detection. Of course, current European recommendation for screening programs only address colorectal, breast, and cervical cancers, but unfortunately, their uptakes remain low. For instance, only 40% of the European population actively participate in colorectal cancer screening. Number 2, the choice of the hospitals. A recent report from Germany showed that the patients with colorectal cancer have a greater chance of survival if they are operating in hospitals with a high caseload, because, of course, complications that can happen after surgery can be better managed in such hospitals. Patients, in our opinion, patients should have freedom of choice in their treatment, including the hospitals where they will have surgery. That's why we are strongly advocate that all hospitals should be transparent about mortality and survival. Surgery requires a high level of expertise and should result from a multidisciplinary decision that includes the patients. It's very important to be in the center of the system. Such expertise is guaranteed in a specialized comprehensive cancer care network model where the multidisciplinary care management, shared decision making, and the 360 degrees patient support are ensured. Unfortunately, not all the cancer are diagnosed in the early stages, so we can talk about neoadjuvant treatment. When possible, pharmaceutical treatment can be used before surgery to ensure patients can undergo surgery. This kind of treatment might make easier to remove cancer, especially if the cancer size and or location might make surgery more difficult. As for surgery, neoadjuvant treatments needs to be conducted in a specialized care centers. And last but not least, nutrition and interventions. According to various studies, nutrition interventions play a crucial role in digestive cancer treatment. Malnutrition in cancer is associated with fewer opportunities for surgical treatment. And a recent study showed that even for cancer patients who are not malnourished before surgery, 14 days pre-surgical nutrition therapy significantly improved nutritional status and reduced postoperative surgical complication. So what we are taking into consideration that nutritional intervention is also essential in the post-surgery phase to ensure intake of essential nutrients and reduce inflammation associated with surgery procedures. Thank you very much.
Thank you so much for highlighting these stimulating key points. And now it's time for me, with a very personal pleasure, to introduce my president. Ladies and gentlemen, Madame Isabelle Rubio, the president of the European Society of Surgical Oncology.
Thank you, Domenico, and thank you, Mr. Busoi, for having us here today. And I'm just going to give a little overview of what is the reality now of surgical oncology in Europe, and I think this is important in terms to improve it. So ESSO underwent a survey in the European countries, the member states, and some others, asking if there was a surgical oncology specialization. As you can see here, 2/3 of the European countries, European member states, do not have any surgical oncology specialization, and only 1/3 has it. And many studies already have shown, and the Netherlands is one example, that in those countries where there is a specialization in surgical oncology, one of the main factors that decrease the morbidity and the mortality of cancer patients is the specialization. So I think it's clear that in Europe we have a problem with this. Of course, we at ESSO, we have one of the missions that we have is the training and education, and we develop a core curriculum in surgical oncology that goes through all aspects of different organ-based cancers and what a surgeon needs to know about oncology to be a surgical oncologist. We also have developed and are going with schools, so maintaining the certification with different schools, with different courses that you can see there and webinars that has increased over the years and are a very important part of our society to train young surgical oncologists in different hands-on techniques and also in cancer management. But also we have a very strong group of young surgical surgeons who want to be surgical oncologists. It's the ESSA group, and ESSO also want to empower and support them in their careers. So there is also one thing about research, and it's already been said. And as you can see here, if we look at the clinicaltrials.gov, is where all the clinical trials are registered in Europe. Only 6% of all those trials are surgical oncology trials. But not only that, an important point also is that only 1% of cancer patients are recruited in surgical oncology trials. Knowing that research, and especially clinical research, is associated with better outcomes for cancer patients. So not only there is not enough funding for research, also there is not enough funding for clinical trials, and this is something that even though in the cancer mission it's already gathered, it's something that needs to be much improved. Also to research and fund for innovation. If we can do better surgeries, we can preserve the organ and the patient will gain in quality of life around their lives. Also the multidisciplinarity. Usually, if you are a general surgeon just doing general surgery, you don't have the idea of what multidisciplinarity is, because if you have to operate on benign disease, you don't need to talk to anyone. You just see the patient, diagnose and operate. But in cancer, it's different, because in cancer, we are a group of specialists who works towards the best outcome of our patient. So we also need to have a great knowledge of what cancer is and a great knowledge of what the other pillars of the treatment is doing to our patients, because sometimes we need to operate, but sometimes we need to give other treatments. In the Europe Beating Plan, and there is this specialty program that ESSO is part of, one of the working package under the European Cancer Organization program. And it's good and it's important. But who is training these surgical oncologists if there is no surgical oncology recognition in the majority of the countries where all these surgeons are going to be trained, or medical oncologists, or whoever? And I think, this is a lack that it's clear there, and we need to take into consideration. We are also part of the Global Cancer Forum, Global Cancer Surgery Forum, that it's the mission to get the voice of the surgical oncology in all the world. So I think it's important also that the European Cancer Plan wants all cancer patients to be treated in comprehensive cancer centers or certified cancer centers, but we need to certify the surgeons to be surgical oncologists. And this is the pillar that we are lacking, because medical oncologists and radiation oncologists are already has their own specialization and certification. And as you can see, ESSO has 22 affiliated surgical oncology societies that, interestingly, even there is no surgical oncology specialization in the majority of the countries, there is societies of surgical oncology. And I think that's a very good start point to have the surgical oncology specialization, because I believe, and we believe at the European Society of Surgical Oncology, that if the implementation of the surgical oncology specialty is not going to be similar in all the member states, there will continue to be great disparities in the treatment of cancer surgery for our patients. Thank you.
Thank you so much, Madam President. Congratulations for the election. I understood it was just not so long time ago, this meeting of today, and a lot of success to ESSO, of course. Before going to the panel discussion, we have a presentation from Europa Donna President, Tanya Spanic. She will talk about the need for cancer patients to be treated by specialized surgical oncologists.
Thank you. And first of all, I would like really to thank you for giving me this opportunity to be a part of this great panel. Just briefly, Europa Donna is an umbrella organization for breast cancer in Europe. And as you can see, it goes way beyond the borders of European Union. We have 47 member countries. Our main activities are in advocacy, sharing accurate information, education, and training of our members, and of course, supporting research. Our main mission is what we already heard several times today, to ensure that all people in Europe have access to accurate information, quality screening, diagnosis, and treatment of breast cancer regarding where they are living and how old are they. These are our 10 goals that we are referring, everything from screening, early diagnosis, treatment, and of course, rehabilitation after the diagnosis in lay public and also in healthcare professionals. Our main activities in public in policy affairs is very important for us, because as we already heard today, how important the document of Europe's Beating Cancer Plan is for everybody. And this document is probably our common document that we all different stakeholders should work together to disseminate it to our countries, and because that this plan will become the reality. We are very tightly involved with ECIBC from the very beginning, and in those guidelines, also Recommendations for surgeons are actually written, but as Isabel said very clearly, we don't have certification and we don't have actual recommendations what this should mean in certified cancer centers. Also was already mentioned by Alina before me, how important is for cancer patients that we are treated in certified breast surgical cancer centers in case of breast cancer within the breast unit, where different healthcare experts from medical oncologists, surgeons, radiation therapists, psychologists, nutritionists are involved in the cancer treatment from the very beginning, from the diagnosis, and all the way through the follow-ups. We know that in some countries, actually surgeons are prescribing also the treatment, which is also not good. So we are all advocating, I'm sure that all of my colleagues from patient organizations would agree that we are advocating for cancer units, certified cancer units, where multidisciplinary teams are treating the patients. And where we see this power of our organizations at, that we are actually working together, that we are educating our member countries, our national advocates to do this in their own countries. Because if we do it just on the top and from the top to the national levels, it's much harder. We have to work also from the other way, from educating the national representatives, national delegates, advocates to work in their own countries, that actually all these our efforts will become the reality. Thank you very much.
Of course, certification accreditation of surgical oncologists and multidisciplinary cancer units across the EU is needed, and I will try to make sure that EU4Health program deliver on the Center for Excellence in Cancer as asked by European Parliament when together with the Council during the German presidency decided the main priorities and the main activities in the EU4Health program.